Welcome to the Turd Nerds. We are the functional gastroenterology podcast discussing all things poop. Before we take the plunge into today's episode, let us tell you a bit about ourselves. I'm Dr. Rebecca Sand, a naturopathic physician and acupuncturist, and I specialize in all things gastroenterology, hormones, and fertility.
I'm Dr. Ami Kapadia, and I'm a medical doctor trained in family medicine and functional medicine with a special interest in gastrointestinal health, food and environmental allergies, and autoimmune disease.
And I'm Dr. Gurevich, a naturopathic physician and acupuncturist who is board certified in naturopathic gastroenterology. I specialize in inflammatory bowel disease, IBS, and other functional digestive disorders. Let's jump into today's episode.
The following discussion is for educational purposes only and not intended to diagnose or treat any diseases or conditions. Please consult your doctor before incorporating any of this information into your care. The information presented on this podcast is not medical advice.
So part 2, more questions about EPI.
We realized we had more to ask.
We have more. So I'm going to jump in before Dr. Sand.
Okay, go.
for it.
So my question was, the people you're getting off of the enzymes by the end of the year or however long it takes, typically you're working on various forms of dysbiosis, as well as kind of just everything we do in integrative and naturopathic medicine.
So, by the nature of who we are, we're always looking at underlying cause.
You don't want to just keep them on the product for the rest of their life?
I think while it's a great financial structure for the drug company, I don't think it's a great financial structure for the patient.
Good.
And I'm not being funny. There are times when I see this drug coming back as $12,000 a month.
Oh yeah, no, I know.
Yeah.
And then I switched them to the supplement.
But that's also $40 to $60 a
Right,
month,
it's not
depending
cheap.
on how much they're taking
Right.
and who is only taking one product.
Right.
Okay, so when I'm talking about how do I get them off, right? Always looking for underlying causes. Do they have fungal overgrowth? Do they have bacterial overgrowth? Do they have protozoa, parasites, or worms? What is their lifestyle like? Do they sleep? Do they eat like a robot or do they eat like a human? How tightly wound are they? Because remember, digestion, including digestion for pancreatic secretions, is based on being in the parasympathetic state. Who eats in the parasympathetic state in today's world, right? So all of that lifestyle stuff really matters. So that's the first thing. The second thing is underlying causes and pathogens. If you clean up the pathogens, the pancreas will often function. There also is a piece of it where when you just give the pancreas some rest, it can actually reboot itself and make itself work again.
Okay, great.
And my favorite thing to do, probably almost across the board for almost all supplements, not drugs, but I like to go 3 months, take a break.
Yeah,
is it back? Let's keep going. Is it done? You're done.
Right.
I like 3 months and a break.
Do you do an abrupt stop or do you...
I do an abrupt stop. And, sometimes that's the information that I get back is, oh, maybe we should just lower your dose.
Right.
The other piece of that is that oftentimes with EPI, they'll know within a matter of days if it's too soon.
That's what I see.
Yeah.
Yeah, and I'm always like, you can add it back in. Let's just do an experiment and see how you do.
And then if they start developing abdominal pain, that's a clue to me that the dose is too high.
Right.
And other side effects you've seen besides abdominal pain, if the dose is too high, it just either works or it doesn't work?
Generally, yes.
Okay.
I've seen some nausea, but it goes away.
I've seen nausea once, maybe twice. And this is a drug I prescribe a lot.
Yeah.
And there's no evidence that it can promote gastritis or anything like that, given we're giving enzymes.
I haven't seen it, and it's not on the list of side effects that we see. And I can understand theoretically how it could.
Any concern about folks with autoimmune predispositions?
So I see that those people are more likely to have some kind of EPI, especially if that autoimmunity is in the GI. And remember, like autoimmune patients, like celiac patients or Crohn's patients, this could, depending on where their disease is and the severity, this could just be a part of their disease.
Right.
It's one of these things that is, so EPI often travels with other digestive disorders.
What about giving pig products to folks with autoimmune?
Surprisingly, I did learn, I know when we talk about thyroid, I was warned, like, be careful with animal-based thyroid replacement for people with autoimmune thyroiditis, but there's definitely people with autoimmune thyroiditis who do better on animal-based products than
I know it's one of those things I feel like I learned too, but clinically it's not what I see.
I will say that I know exactly where I learned it. And the person I learned it from is a genius. He's exceptionally smart, but not necessarily the best clinician. And so I can understand the theory, but that theory did not, for me, play out clinically either.
Yeah.
And when we're talking about dosing for the over-the-counter supplement versions, I learned from a very smart doctor, Sand, that you can sort of get an equivalent dosing. It's quite high, I feel like, in the 3 to 5 to 6 capsule range to be equivalent to one of the prescriptions. Do either of you have
So I
more?
can tell you there are two products.
I don't think we can.
Okay. So there are two products. One of them, 2 pills is 17,000 units of lipase. And the other one, 2 pills, I think it's either 20 or 25,000.
So how does that
So
compare to the prescription?
at the moment, the drug companies, what happens is they run out of their patent and they make a higher dose and then they push a higher dose, right?
Okay.
So at the moment, they're pushing their 36,000 or 40,000 equivalent, depending on what company you're looking at. And last time before their patent ran out, they were pushing their 25,000 or 20,000 equivalent.
So it'd be 2 to 4-ish?
So it would be 2 to 4 pills with meals, possibly higher or lower depending on need.
And I'm still confused about how we figure out dosing and like the factors that go into dosing. I have looked in the past at tests, like how low their elastase levels are.
I mean, I think that's as good a place as any to start. You're confused because there is not anything solidly to hang your hat on. Like, I mean, that's why the reality is you start them. Is it working?
Yeah.
Go up, go down,
Right.
look at the calculator, double, triple, depending on the calculator says. Don't go over the calculator because I think that's kind of borderline malpractice. Knowing full well that when they release their next series of products in 5 years, you're going to go over the calculator because everything's going to change. But don't go over the calculator. But the calculator, like I had a patient who was like 120-pound female, and I looked at the calculator for her, and her dose was somewhere between 25 and 150,000 units.
Exactly.
Yeah.
And is the calculator weighing in cystic fibrosis or not?
No.
Yeah. So
I don't think so.
I don't think so either.
Yeah.
I've looked.
So I have a patient who has chronic diarrhea with urgency. It's gotten somewhat better with treating dysbiosis, but as you both know, my original teaching was always go after root cause, and I was a little bit late to the boat on symptom management, and this is more than symptom management. So we have been trying him on enzymes the past year. They were over-the-counter enzymes. There's been no change with 3 to 4 to 5 of the over-the-counter. So can I pretty much rule out EPI?
Okay, so my first, so I hear that case, right? And my first thought is, when was he scoped last? Has anybody ruled out microscopic colitis? Has anybody ruled out inflammatory bowel disease?
So he did have a full GI workup. I have to check when the last scope was. And we're going to do an episode on microscopic colitis, but let's assume those have both been ruled out.
I would try the drug.
Even though the dose is the same?
I would try the drug just because, depending on who you talk to with the drugs, like the supplement products are just veggie capped. Right. And so theoretically, that supplement product is dissolving in the in the stomach, and the stomach is probably breaking it down somewhat before it goes into the small bowel where you actually need it. Right. So then I would start with a drug, especially one of the drugs that's pH balanced to dissolve in the duodenum.
Okay.
And I would give that a go.
And that's both of the commercially available
preparations? Those are,
okay.
I think there's 5 commercially available preparations.
Okay.
Yeah.
We've used 2. Okay.
And, so then the next thing you want to do is if they're meeting a steatorrhea picture, because that's the question, do they meet that steatorrhea?
Because not everyone with diarrhea does.
Because not everyone with diarrhea is having a fat malabsorption diarrhea. If they're meeting a steatorrhea criteria, at that point, you give them the the drug, the bile acid sequestrant. Yeah.
And we would determine steatorrhea, as we talked about previously, by often clinical symptoms, because we're not going to do the 24-hour stool collection. Okay.
Right. And you can theoretically do a fecal fat stool collection, but that's not
the qualitative.
Right. But that can miss a lot of people.
And do you think the average patient who is going to a GI doctor, you'll probably get into this more in the future, are they ruling out microscopic colitis?
So this is an interesting thing for me. I'm going to say it depends on the gastro.
Okay.
I have one patient in particular who, oh my God, this guy, probably I'm like his 60th physician, either gastro, naturopath, functional medicine, like whatever. He has atrocious diarrhea, but he was just very phobic of gastros. And so he hasn't been back to a gastro for like a decade, but he's still having the same diarrhea he had a decade ago. And I sent him to the gastro, to a group that I like.
Right.
And I wrote them notes saying, I'm sending you to rule out microscopic colitis. But the gastro kind of zonked out. He's on a procedure every 15 minutes.
Yeah.
He saw that this is a man that was over 65. So he was like, traditional colonoscopy.
no.
For colon
Did not do
cancer.
any biopsies.
No.
Did not do, they put him under. He had to do the prep, tortured him. You know what I
poor
mean?
guy.
And so should they be looking for microscopic colitis? Yeah. But let's be honest, the three of us treat a lot of patients. It's hard to remember what you're doing when you're treating a lot of patients.
Right.
So it should be in their field of vision.
Okay.
And oftentimes, and by the way, this patient also, before he went under, said to the gastro, remember, we're screening for microscopic colitis. Yeah.
No.
The gastro just zoned out.
No.
Yeah.
Oh,
So to kind of
disappointing.
summarize that, in patients with chronic diarrhea, we of course always want to rule out inflammatory bowel disease, microscopic colitis, which we're going to talk more about, bile acid malabsorption, EPI,
Pancreatic.
lactose intolerance. What else?
anything with the
Fructose
microbiome.
intolerance,
SIFO,
parasite,
SIVO.
Dysbiosis. Those are well within what most of us think about, I think. But so that would be like a good summary. And the other sort of thing I can't figure out is why are patients not getting tested for fructose and lactose intolerance routinely with breath tests these days?
So they are. It depends on who you go to,
Okay.
right? So within the alternative medicine community, the easiest access that we have for a test is lactulose or glucose, right? However, you could absolutely also order fructose and lactose. And you can't do more than one solvent
Okay.
per test.
Okay.
And a lot of these solvents each either need you fasting or they need you provoked. And so like that's the question. You kind of have to prioritize.
So can we run those tests on the machine we have? The fructose and lactose breath test?
I
Is
don't
it the
know.
same breath test?
a good question.
It's definitely a different reagent.
Right. But I don't know if the
I
collection
don't know.
Okay. Because I feel like that should be routine, and I feel like we don't do it.
Because I've definitely, I think it's similar to cumbersomeness.
You'd have to go in 3 days in a row, do
or
lactose,
3
fructose,
days
and
over the course of a week, every
Right,
other day.
Right. And
It's
I don't know if those
cumbersome.
require a prep diet or not.
Right.
So that would be good for us to know.
Have on the radar. Yeah.
Yeah, I mean that's the problem
future.
is I think the cumbersomeness, and so that's why whenever we talk about anything, the history is by far the most important,
Right.
and you're trying to see what you're listening for.
So on that note, I'm a little bit more curious about diet with these folks. Like, do they come in talking about diet issues, restrictive foods, or foods they're restricting because it manages symptoms better, like high fat meals, fried foods? And then do you find any role with diet in treatment?
So I will say that these patients so they don't have pain.
Mhm.
And that's like a thing, you know what I mean? Like you're very, very motivated to decrease or change your diet if there's pain, right?
There's no fullness, early satiety, bloating.
There's definitely fullness or early satiety and bloating.
Okay.
There's definitely
not pain.
diarrhea, not pain.
Okay.
I will say that historically speaking, I do often see these patients self-selecting to not eat fat or decrease the fat in their diet because that is often a very clear trigger. Or they will say, oh, I went out for wings and I had the usual diarrhea. I call it, Timbuktu, whatever diet. Like they'll often notice it that way. Can diet affect symptoms? Absolutely. But the other side of that is it's like they can basically be down to eating nothing just because they're afraid of getting the diarrhea, which also, when going back to fat soluble vitamins, like that's a big deal if you're not absorbing your fats.
So is there any difference between folks eating fats paired with fiber versus just straight like fried foods, fast foods?
Sometimes.
Okay.
I mean, I would think they'd feel bad just every time they eat because they're not secreting any of the enzymes properly. But clinically, you're saying you see potentially more of an issue with fats than other macronutrients?
Yes, for sure. And I think that they just feel bad. But remember, there's a severity gradient, right? So the mild patients, it's like kind of more sporadic when they really push it. And the severe patients can't eat anything.
And so that's a good sort of clue because we usually think of with other overgrowths like protozoa, SIBO, SIFO, they typically don't deal with carbohydrates. So if we are clinically seeing a little bit more of issues with fats, that could be a good tip off.
That is incredibly insightful. Yes, that is correct. When you are seeing that fat malabsorption, steatorrhea stool, you are generally thinking EPI or bile acid malabsorption.
All right. Good to know.
And, microscopic colitis, that, it's so interesting. Like when I think about diarrhea, like I feel like I have this intimate relationship with diarrhea, especially when I'm asking my patients, like, is it a watery diarrhea? Is it like a more porridge-like diarrhea? Do you have steatorrhea? Are you cleaning your toilet bowl again and again?
Yeah.
Are you belching? Does it start up or high? Does it, like, microscopic colitis is going to be a very different diarrhea than an EPI or bile acid malabsorption diarrhea.
Okay.
And then all of these conditions have gradients in severity. And so that needs to go into your thinking.
All right. So I feel like back in the day when my mentors were practicing, it made sense to just go after the root cause because you could actually fix it. And now it's like it takes several years to fix the root causes. So it makes sense to treat the symptoms and the downstream effects because it's going to take so long to fix the underlying causes.
I have to say, in my experience, I get better compliance and better faith in my work if I go after symptoms and then explain why we also need to treat the underlying causes.
I think that's a good point. I also have the patients that are like, I feel horrible, but I'm not going to do anything unless it's like treating the underlying cause. And that's become very frustrating because sometimes we can't treat the underlying cause until these downstream effects are a bit stabilized, like everything we talked about. Plus we'll do an episode on MCAS histamine intolerance, which some people just are opposed to medications. And so that becomes challenging. But yes, it does seem to, I feel like most people, if they're feeling a little better, they'll be more likely to stick with it because it is going to take, I keep changing on my paperwork. We'll be working together for this many months. Oh no, we're going to be working together. Now it will be several years.
Yeah.
Is what I changed it to because it's going to take that long.
I don't know about you, but the majority of my patients have been feeling sick for
a long time,
like decades.
But somehow some people still have an expectation of a more immediate turnaround within a month's time frame. And I think it's important to
culture.
It's our fast food nation, but it's important to set expectations.
So in your experience, what are the top underlying causes that you actually see clinically?
So inflammatory bowel disease, probably self-selected because of the nature of my practice, bacterial overgrowth and fungal overgrowth, upper GI issues. And then I will also say lifestyle plays a role. Like I am not being funny. We think we live as if we're robots.
Yeah.
And our physiology is excessively complicated and very, very tuned in with our balance of sympathetic and parasympathetic, but our lifestyle is just very sympathetically dominated.
Yeah, for sure. We got to pay attention to that probably in everyone. I am a little bit confused about the diarrhea picture because I have had low elastase in constipation folks who have gotten better with enzymes.
So that's an interesting thing, which I have also seen. In those patients, if we're honest, I am not as comfortable using the pharmaceutical pancreolipase.
Yep.
I feel significantly more comfortable using herbal supplementation with some pancreolipase amylase protease in there, but also working on the brush border.
So could it be that those folks have a motility disorder and EPI?
I mean, EPI likes to travel with a lot of other disorders.
So in the case of someone having an underlying cause of perhaps methane positive SIBO and EPI
or SIFO.
Right.
Because I don't know. I know that when Dr. Kapadia did her SIFO, incredible, our first 3 episodes, they were like the best.
Amazing.
That's what like hooked me into this podcast. When she did that, she talks about how when she sees SIFO, it's a lot of diarrhea.
Yeah.
But I see SIFO.
I see a lot of constipation. In the research, they saw diarrhea.
Got it. That makes sense.
Yeah.
Because I see a lot of constipation with my SIFO people.
I do too.
Constipation,
I wonder about
bloating.
research if they're just targeting diarrhea folks, or if diarrhea folks are better reporters than constipation folks.
I feel like it was the articles I looked at were for IBS patients across the board, so I don't think they were selecting for diarrhea, but I'm not sure in other studies.
I also will say, if you have talked to enough patients, the definition of constipation alters greatly from patient to patient.
Big time.
And no, it's normal. Right. I poop 1 time every 10 days. That's normal.
Yeah.
No. Yeah.
I had another question that I can't remember. Do you find the elastase on our functional medicine tests I know you've mentioned they may not be as accurate as the standard lab tests for fecal elastase?
Elastase I find very accurate on both
Across the
functional.
board?
Yep, both
Okay.
functional and
Okay, good to
regular
know.
lab tests.
Do you ever retest?
Always.
Okay.
Well, I'm not going to say always. I'm not going to say always. I will retest if they've been on a treatment plan for a long time and then we pull them off and they are not better.
Yep.
I kind of want to figure, because, we're like, I usually think of EPI as traveling with another disorder, right? And so I am often looking at what does the other, like, is this still the main problem or are we dealing with something else now?
A little bit different note. I have had patients who had very low elastase on stool tests, like a 6, 4, something like that, and they're they were perhaps with an insurance that didn't allow me to prescribe, and sent them back to their gastro. Their gastro immediately did pancreatic imaging.
So you're looking for you're looking for like
Pancreatitis.
pancreatitis or pancreatic cancer,
Right.
like that's appropriate.
Is that part of your standard workup when the elastase is below a certain threshold?
I feel like I have to match symptoms with presentation with objective findings, and it's always in my thinking.
Okay, so that's an important point. If you're starting to check elastase on patients and it's significantly low,
in the absence of diarrhea,
and just
or
remember,
in the absence of diarrhea, you may want to consider imaging.
Just remember, pancreatic cancer is often diagnosed very late when it metastasizes. So that absolutely needs to be in your thinking.
Yeah.
So it would be good to know at some point to talk about, okay, when do we pursue imaging in someone with a low fecal elastase?
I mean, I don't feel like there's a magic cutoff.
Okay.
I feel like there is a really proper workup. How long have they been dealing with this? How severe are their symptoms? Have they had any recent red flag signs recently? Weight of loss. Yeah, the typical thing that we're looking for. Yeah.
Yeah. All right. Good,
but I will say that, yes, I absolutely agree. A very low elastase warrants a further workup.
And potentially then check an amylase lipase and imaging.
And then take a blood amylase lipase, a serum amylase lipase, and imaging, correct.
Okay.
And that's imaging is often an ultrasound.
They don't go to CT for that? I think
the gastros I've seen do CT.
So maybe I'm wrong.
For acute pancreatitis, we would always get a CT. But yeah, so we'd have to look, but probably CT. Last question. What do you think the overgrowth is doing to affect the pancreas? Do you think it's just upward signaling that's messed up?
So I don't have any data. So I'm basing this on my opinion. I think that because of the bacterial overgrowth, the entire neurologic communication network is not functioning optimally.
Okay. All right.
And there probably is something microbiome wise.
I mean, when isn't there something microbiome wise?
Just gonna put a little bookmark in there for future research.
It's just it's really hard right now. It's just our human. We're just so complicated. Everything that we do, and we didn't even talk in this episode about all of the things that deregulate our neurological and hormonal communications. Remember, the small bowel has something like 100 different hormones that are signaling for digestion. All of that also gets interfered with as well. And then plus these patients generally have a fat malabsorption. So there's also some hormonal changes that way. Like it's a little bit of a self-fulfilling prophecy.
It's a cycle.
So that's what's hard.
Okay. I think that's all we've got.
I'm so glad we did a part 2. Turns out we had way more questions than we thought. Yeah.
Okay, guys. See you soon.
Okay.
Bye.
Thanks for joining us today. Stay tuned. We release episodes every 2 weeks.
If you like this episode, please subscribe and don't forget to rate and review us to help spread the Turd Nerd word.